Hi, everybody. So I've got another interesting ECG that I came across yesterday, and I thought it's something we could all benefit from because it's something we've actually seen quite a few times on our group before, and hopefully some of you might already pick up what's going on, but try and show it to you anyway. So this was actually a young gentleman who presented with severe chest pain and was brought in, had no other comorbidities, and generally quite healthy, and came in with a history of the centralized chest pain that was actually radiating to his back as well. So we're just going to have a quick look at it. It's not going to be too long today. It's going to be a short one. So the first thing, of course, that we look at is that we look at the axis. Let's try and get that up over here. Hopefully I can do a better job than the last time. So if we look at our quadrants over there, we've got our leads 1 here and our lead AVF on this side. And we've got the normal, the left, the extreme right, and the right. So let's just have a look quickly at his lead 1. So lead 1, primarily positive. So that means it's either in the left quadrant or in the normal. And if we look at lead AVF, where is it here? There we go. Lead AVF is also in the positive. So we can say that lead AVF is also seeing electricity coming towards it. So it's either there or there. And since both of them coincide in the normal, we can say that we've got a normal axis. Let's have a look at the rhythm. So the first thing that we notice is that we've got a very long PR interval. You can actually see it from here. I think it's better noted there. You can see it somewhat here. So we've got a long PR interval that's going on over there. So we've got 1, 2, 3, 4, nearly 5 blocks. And once you see an elongation, you need to see, is it consistent? Is it worse? Is it getting better? And then what we see is that we've got 1, 2, we've got long. It seems to be getting longer. And then we've almost got like a miss over here. So we've almost got like a mist that's going on, and then we can see it shortens up immediately after that. So we've got this long and then like a pause, even though we don't see a P wave in front, and then we see that it again starts to it starts to get longer again. So we've actually got a Morbitz type 1 that's going on over here. So that's one of the things that we can pick up. So this is a rhythm disturbance as well. So we've got a Morbitz type 1 that's going on. We've got narrow QRS complexes. Do QRS complexes follow every P? No, because we could have a possible P wave here, although it doesn't pick up so well. And here we could see a possible where the gap is. We need to look for a P wave. We don't really see it, but it may also be because of the orientation of the leads around there. So it could be a bit of sinus arrhythmia, but what's making me think against that is the definite elongation and then the sudden decrease after that. So there could be just an orientation of the leads that's leading to us not seeing another P wave somewhere along here. All right, so that's one of the things that we picked up. So this could be well a rhythm disturbance, a Morbitz type 1, so you could well have a problem with that. So what could be the reasons for that? That's what we need to look at now. So in his case, let's have a look at each. Well, the rate, if we go at the narrowest point, is about 70 beats per minute. So he's not really tachycardic or bradycardic, despite having a possible Morbitz type 1. And then we've got to look at each and every zone. So let's look at the inferior zone, which is 2, 3, and AVF. And the one thing you'll notice is that we've got these slight ST elevations that are going on. And we've also got the slight dip in the in the PR segment. It's not tremendous, but it is there. And especially with an elongated PR, it's sometimes difficult to see, but it does seem to be slightly down, but we can't confirm that 100%, but there's definitely an ST elevation. So the next thing we've got to look at, and remember, these are all our rhythm strips over here that we're looking at. So when we were looking through all of the rhythm strips, remember, we couldn't see the extra P wave that would definitely tell us that this is a Morbitz, but it's a possibility that it may be there and there's an orientation problem that's going on. So if we look at the septum, so look at V1, V2, we can see a slight ST elevation here. But remember that when you have a patient who's less than 40, as in the case of this patient, sorry, I just want to get the right line over here. Let's try and get that here. So when you've got a patient who is less than 40 and male, anything more than 2.5 small blocks is a problem. So here we can see, and that's in V2 and V3 that we're looking at. So it could be benign early repolarization, but in this case, especially considering the other ST elevations that we've seen, it's highly unlikely that this is benign. However, you'd only get worried once it's above 2 to 2.5 blocks. If the patient is above 40, then definitely over 2 blocks is a problem. And if it's a female patient, over 2 blocks is a problem, regardless of age. When we come to the anterior parts of V3, V4, again, we can see this slight ST elevation. It's there as well in V5 and V6, although not to such a great extent. And when we come to 1 and AVL, we don't notice much of an ST elevation at all. If we had to draw a line across, you can see there's not much of an ST depression either. There's a bit of PR elevation, but that's about it. But there's maybe a slight ST depression, but not really there. And we can see that there's no PR elevation here in AVR as well. So we've got this issue of multiple ST elevations and a rhythm disturbance that's going on. Now, one of the things that you have to consider is pericarditis, which is definitely one of the problems that may well be associated with this. The other, of course, is acute ischemia, and a severe acute ischemia as well, which cannot be ruled out in a young person and could well lead to rhythm disturbances like what you're seeing there, because it depends where the infarct may have occurred as well. Then, of course, you look at things like ventricular aneurysms and things like that, which you don't really consider in a younger person, but could well be there in an older person. So these are the three diagnoses that we've got. So it's possible that this could be a pericarditis. It's possible it could be an ischemia, and quite a significant ischemia. And the other thing is that it could just be an isolated heart block as well, which could be a Morbitz type 1. Although I'm not convinced, because we don't see, we would be expecting to see a P wave somewhere around there, but there is just a little, let me just highlight it a bit better. So we would expect to see a little bubble around there, and you can sort of see something, but it's not really there. And then you see your PR interval is quite narrow. In fact, it's normal there. And then, it starts to elongate again. And here you can see it's quite elongating even more. And then all of a sudden we get almost back to a normal PR interval. So that's what's making me think of a Morbitz type 1 with a narrow QRS complex. But the reason for the Morbitz type 1 could be infection or infarction. So these are the things that we see in this ECG. And so in other words, now you are now sitting in an emergency department. What do you do? So it's quite simple. You take your infective markers, so your procalcitonins, your CRPs, your ESR, depending on what you've got access to. So your inflammatory and infective markers, your full blood counts, your UNEs, but you would also take your cardiac enzymes. And in any case, you should take your cardiac enzymes, even if you suspect that this could be a pericarditis. You can never rule out ischemia. And the other thing to do in this case would be to get a blood culture as well, if you can, prior to antibiotic administration. But even if it's after antibiotic administration, just make sure you use the right culture bottle, and that's about it. So what I would do for this patient, if this patient were to come to me, is that I wouldn't worry too much about the rhythm disturbance. It's definitely there, but it's not the main problem at the moment. The main problem is the chest pain. So you would clinically try and differentiate by getting the patient to lean forward. If it aggravates the pain, you think, okay, this could be and is relieved by going back, and you lean more towards pericarditis. If that is not the case, then you think, okay, you know what, it may not be. And it could well just be ischemia as well. So you would treat the patient with empirical antibiotics in this case. You would treat the patient as an acute coronary syndrome because you're not 100% sure of what's causing the rhythm disturbance as well. So you need to look at that also. And then, having looked at all of those, you need to then now get the patient to the right areas. And I suppose this is a patient, depending on their stability, could well end up in the ICU, would need an urgent echo, probably need a PCI, depending on what the echo finds. I wouldn't thrombolize this patient immediately in the emergency department, simply because we don't have a definitive diagnosis, and you'd want to get a definitive diagnosis before you go ahead and say, okay, I'm thrombolizing. But it's just an interesting one, an interesting case that came through. Now, I don't know the outcome for this particular patient. All I know is that the patient was transferred to one of the tertiary hospitals, but what exactly they found after that, I haven't been privy to. But this was a nice one sent in by our doctors during the day shift. So I just want to thank them. It was quite a nice one to actually go through with them. But as far as I know, the patient was transferred to the ICU in our hospital and investigated, as I had mentioned. But what happened after then, what the final decision was, I'm not sure. As far as I know, he did go to the cardiologist because they couldn't come up with a definitive diagnosis. I think there was evidence of myocardial damage, but there was also evidence of pericardial involvement as well. So it was quite strange, along with the, from my understanding, there was a continued rhythm disturbance as well. But I hope I'm not mixing it up with another patient. Anyway, thank you so much. I hope you guys enjoyed that. And yeah, hopefully we'll have another interesting case soon. Keep well. Bye.